Um, Hi, thanks everyone who has joined. I feel honored by the opportunity to present in this seminar series. As Camila mentioned, today I will discuss the role of competing events in dementia research and talk about several estimands. I hope that we can engage in conversation during the Q&A. And yeah, so I look forward to reading your questions. Alzheimer's disease and related dementias are a global public health issue that disproportionately affects women and underserved population, including those in low-middle income countries. Despite the growing burden, there is limited evidence in the underlying causes and little success in developing effective therapies. The National Institute of Aging has proposed a health disparities research framework to conceptualize environmental, sociocultural, behavioral, and biological factors contributing to dementia. And the goal is that future research can identify causal pathways and interventions to reduce dementia disparities. Now, this includes exposures that are often considered ill-defined, and I would be very happy to discuss about ill-defined exposures as well in the Q&A, but for now, I ask you to keep an open mind and embrace that dementia research aims to answer causal questions about complex exposures. Now, a challenge we face is that most of these factors also impact death, which is a competing event for dementia. Now, specifically, competing events are those events that preclude the outcome of interest. So they prevent the existence or occurrence, or they make it impossible that once the competing event has happened, the event of interest will not happen anymore over follow-up. And how does our data look like in the meshes research, especially in cohort settings? Is that even if we start with the best study design and have all the population at baseline with a line time zero between the exposure measurement and follow-up, we know that over follow-up, just as people will start developing or being diagnosed with dementia, we will have people who die without dementia diagnosis. And this means that our at risk set is decreasing over time. And the way we handle this is going to be crucial, especially in observational data, because if we don't handle it well, it can lead to erroneous interpretations. So for example, in 2016, a group of researchers concluded that people that smoked had a lower risk of dementia compared to never smokers, and used an inductive approach, meaning that they first analyze the data and then they derive the hypothesis that could be driven by these results, to explain that maybe nicotine could be the biological mechanism that drives this association. A few years later, a new study found that there was no association after accounting for the competing event of death. Um, so here they said, and adjusting for the competing risk of death without dementia. But what does adjusting or accounting mean? What is the method of choice in this setting? So several statisticians and epidemiologists suggest that cause-specific hazard ratios should be used to address etiologic questions, and subdistribution hazard ratios should be used for estimating any incidence, predicting prognosis, and other papers say for health policy research. But these recommendations are not emphasizing the interpretation at all. So during my PhD, I performed a systematic review to see what was the most common approach for handling competing events in dementia research with causal aims. And I looked at several important journals of dementia research and specifically identified those who were looking at longitudinal or cohort studies and were reporting hazards of risks, and that we're interested in time to dementia or Alzheimer's disease as a primary or co-primary outcome. And because we know that most applied research talks about association, it's very hard to understand which papers have causal intentions. So we define these as papers who have a clear exposure or intervention and that use methods to handle confounding and that were not clearly descriptive or predictive. So what we found out of 57 papers that we finally included is that half of the papers report death numbers, but only a fifth report death by exposure level as in descriptive statistics. Half do not include any description about death in the method section, and 25% consider competing events as part of a sensitivity analysis. Now, most papers use Cox proportional hazard models and present hazard ratios. And the challenge is that most papers had inaccurate interpretations. So they were presenting hazards as risks. And we know that when competing events are present, there is no one-to-one relationship between the hazard and the risk. So interpreting hazards as risks is misleading. Now, many of us are likely familiar with the intrinsic limitations of hazard ratios, and despite methods available to move away from hazards and derive adjusted cumulative incidence and contrast, these approaches are underutilized in applied research, as we could see in the systematic review. Now, addressing this gap is critical, as misinterpretations can lead to flawed conclusions. So, for instance, several studies suggest that hypertension at older ages might reduce the risk of dementia and refer to biological mechanisms to support this claim. So, in a recent project from my group at UCLA, we showcased that indeed hazard ratios for the relationship between hypertension defined with a landmark analysis and dementia incidence. If we look at hazard ratios from a Cox model, we can see that this relationship shifts towards the null at older ages. However, when we look at the absolute risk difference, we observe a very different story. Individuals with hypertension have a higher cumulative incidence of dementia over time, and with differences growing substantially at older ages. So I feel that this reflects that, oh, sorry, my slide is missing, but it reflects that there is a lack of communication between methods research, applied research, interpretations, and science communication. Now, fortunately, during my PhD, Jessica Young and colleagues published this fundamental paper a few years ago, which connects causal estimands to common estimators used in survival analyses. And this paper is fundamental because it bridges the two worlds, causal estimands and common statistical methods that are often used in applied research and in statistics. So a few years later, we translated that paper to an EPI audience, and now I will discuss this work. Let me check if there are questions so far in the chat. Or I don't think so.
I think we're good. No questions at the minute.
Okay, great, thank you. So to recap, let's discuss first what are causal estimands. And these are, when I refer to causal estimands, I refer to contrast of counterfactual outcome distributions in the same individuals under different levels of exposure. So the only explanation for a difference is exposure, not comparing different individuals. Now we saw in one of the first slides where we see that people are dropping off the study because they died. So our sample is changing over time. If we have an exposed group and an unexposed group with different mortality rates, that means that they are not only going to be different on their exposure or treatment level, but it can mean that over follow-up, we are comparing different people. So, for example, in this case, I'll bring an example about smoking and dementia. Let's say that we're interested in an exposure where quitting smoking is our exposure of interest, and we want to estimate the risk of dementia at 20 years of follow-up. But we know that there's people who might die by previous time point. So let's say by time 19. So this is why we have death we have death here. And we have this bolder arrow between death and dementia because we know that if people have died by time 19, then their dementia risk at time 20 is equal to 0. So there is this deterministic relationship between death and dementia. And we include these C that are shared risk factors between death and dementia. That could be any cardiovascular comorbidity, cardiometabolic confounders. Now, in the observed data, by conditioning among those who survive, we are creating this box around death, meaning that to condition on this collider. And this is what is commonly known as collider bias, right? Because we're opening this vector pathway between dementia, C, death, and smoking. But with the description of the following estimands, I'll show that it's not necessarily bias, but bias will always refer to the question of interest or to the estimand of interest. So for example, under a total effect, the total effect is a question that says, what is the risk of dementia at 20 years of follow-up had all individuals stopped smoking compared to had all individuals continued smoking? So here we look at the probability of Y, which is dementia, at 20 years of follow-up, had everyone had followed treatment level A equals 1, minus the probability of dementia risk, had everyone had follow treatment or exposure of A equals 0. And what this means is that we are capturing both the direct effect between smoking and dementia, but also the indirect pathway that is open by conditioning on death. So this means that if we actually see an inverse association between quitting smoking, so that quitting smoking reduces the risk of dementia, under a total effect, that is not bias. That is just because the total effect is capturing that smoking is killing people. Now, when I say risk, I am actually referring to the cause-specific cumulative incidence or crude risk, which have been commonly described in statistical literature. As opposed, when we're interested in a control direct effect, this is a question that says, what is the risk of dementia at 20 years of follow-up had all individuals stopped smoking and not died during the study period compared to had all individuals continued smoking and not died? So the difference in this estimate is that we're adding here a D19 equals 0, meaning that we're not only assigning certain level of exposure to everyone, but we're also preventing them from dying in both scenarios. So this is a way to isolate the direct effect between smoking and dementia. And the way we do this is that we conceptualize the competing event as a censoring event. So for example, what we are assuming is that we can remove that direct arrow between death and dementia as if death was a censoring event, such as loss to follow-up. And by conditioning on C, we're blocking this indirect pathway between dementia, C, death, and smoking. Now, this risk has been traditionally been defined as the marginal or net risk in statistical literature. So what are the identifiability assumptions for death specifically? In addition to thinking about exchangeability, positivity, and consistency on the exposure itself, but only focusing on death. So in terms of the competing event of death, under a total effect, we don't need an exchangeability assumption. But under a control direct effect, we need an assumption that says that death is independent of future outcomes had everyone had followed each intervention, A equals A, and death was eliminated conditional on covariates. And this exchangeability assumption is what is often called the independent censoring assumption in statistical literature. Then we also have positivity. For the total effect, we don't need one, but for the control direct effect, we are assuming that at every follow-up time, there are individuals with any possibly observed level of A equals small a and covariate history of those who remain alive and free of dementia diagnosis. And in terms of the assumption of consistency, for a total effect, we don't need one, but for a control direct effect, we need to make the assumption that we have an intervention that eliminates death and that this is well defined. So let me check if there are questions so far.
No, I think we're good.
Okay, great, thank you. So for example, in the paper by AJ that is in American Journal of Epidemiology, we show that indeed, if we target a total effect, then smoking cessation would increase the risk of dementia. But if we are interested in obtaining a control direct effect, what we find is that smoking cessation would decrease your risk of dementia at 20 years over follow-up time. So you can see that these are very different conclusions under very different estimates. And of course, we see that smoking cessation on dementia risk would dramatically decrease the risk of mortality, as we expected, right? Now, in this work, we also show that depending on how we chose to evoke exchangeability, we can get very different answers. So we could have evoked unconditional exchangeability, which would be the most unreasonable setting. So just assuming that there are no C that connect death and dementia, but it's only that death and dementia are independent of each other. And this is what pretty much everyone in applied literature, when you see that people say we treated death as a censoring event, but then they don't explicitly say how they are going to satisfy the exchangeability assumption, then it's pretty much as saying that they believe that death and dementia are independent. But we could alternatively evoke a conditional exchangeability only on baseline covariates. And what we did in this project was we evoke conditional exchangeability on baseline and time varying covariates. So C was time varying or time, and we see that the more we relax the exchangeability assumption, then we see a larger effect on reducing the risk of dementia had everyone had quit smoking. Now, still, this was a sort of a toy example. There are many things that we could have discussed about the study design, but this is just for you to get the picture that depending on the estimates you have and the assumptions you're willing to take, you might get very different answers. Now, since we know that exchangeability assumption is not verifiable, if we are concerned about how well we can satisfy this assumption, or maybe we just don't have sufficient data, we can also calculate bounds for the control direct effect. And these are a way to evaluate extreme scenarios of dependency between death and dementia. And shout out to Nan van Helloven, who will be talking in the next Causal seminar series, because she has brought these bounds to my attention, and by using the Pearson bounds that were described decades ago. But a lower bound is would be a way to capture or to imagine an extreme scenario where all those who died would not have had dementia ever. And this is equivalent to the cause-specific cumulative risk or contrast or the total effect. So the total effect can actually be the lower bound of control direct effect. And as an upper bound, you can imagine an extreme scenario of dependency where everyone who died would have had dementia around the same time of death. And this is equivalent to calculating a total effect for the composite outcome for dementia and death contrast. And I think these bounds are really cool, and we don't use them enough. So I hope that Nanba and Helloven is also talks about these or pushes people to implement them as well. So in recent work, understanding the effect of the acute event of stroke on dementia risk in Asian American population and white population in California, we found that, for example, if we would target a direct effect, then stroke can truly increase, like has a very large effect on dementia risk. But compared to a total effect, that would show an opposite result. So what we did for this work that is under review is we opted to show both and discuss the interpretations and assumptions for both estimates and both results at the same time. Because sometimes I think that in applied research, especially when you see that there's such a large opposite effect, then like choosing which estimate should we is the best approach can be controversial, to say the least, and we just better show all estimates that are possible. Now this is very important because competing events, to conceptualize the issue with competing events in health disparities research. So we know that when we're looking at health disparities, let's say in dementia, we know that mortality rates are often higher for marginalized populations. So even if we're interested in a descriptive or predictive or causal contrast comparing dementia risk between two groups, what we can define as a disparity estimate, this estimate will be impacted by differential mortality as well. So we can either allow this disparity estimate to be mediated by the effect of death. And for example, as we see that women have a much higher risk of dementia compared to men, but this can be partially attributed of men having higher mortality over time and at younger ages compared to women. Or we can choose estimates that somehow remove the impact of the differential mortality between groups. And also, we have to conceptualize that when we are looking at effect heterogeneity and we run stratified analyses by groups, then this effect heterogeneity can also depend on the distribution of competing events if it varies by group. So are there any questions in the chat?
There are, yes.
Okay, so maybe.
You can open the chat if you want to have a look at them, but I'll speak them as well so everyone else can hear.
Okay, yes.
So there's two actually. So the first one is in the example of smoking death dementia, would the following be a problem? When smoking is a cumulative exposure, e.g., smoking history over the years, people might have been dead before they entered the cohort, i.e., they entered the cohort is whether they enter the cohort is counterfactual variable that depends on the exposure. If this is a problem, how do we deal with it?
Okay, thank you so much for that question. Yes, that's actually going to be one of the points for the current research I'm trying to do, because I think that it's definitely a challenge. We can look at, yes, it's definitely a challenge, and there are no clear answers on how, not just to, so I don't think we can solve it until we can understand what would be the ideal estimate that we want to capture if we could have had that missing data first. So first, like, think what we are trying to do now is like first think, okay, in the ideal scenario, if we could have done this target trial and like include everyone and align their smoking, let's say smoking cessation intervention at earlier ages, um, what would be the estimate that we're interested, because we're still going to have death as a competing event. And then when we are missing that amount of information, because cohort studies of elderly participants already start like very late in time, like around 65 years old. So we're losing all those people from our denominator. And currently what we're trying to do is first try to match what are the possible estimates that we were interested in the first place, and how far are we moving from that when we don't have these information on who were initially at risk. Um, and that's just like a fundamental issue that we have in any life course epidemiologic research study when we're interested in aging outcomes. So not solutions yet, but that's where I want to get. But we first have to understand what we can do when we actually have like only looking at the observed data. Um, yes. And like after time zero, let's say.
Great, thank you. There's a few more questions, but maybe we'll just take one more for now and then you can continue. So this question relates to the tables from the AG paper that you showed.
Mm-hmm.
This person wants to know if you could explain how these models differ, because they want to understand how, sorry, they understand how they differ conceptually, but they want to know how the actual estimation differs. In one model, is a certain variable included, and the other model is it not, for instance?
Okay, great. Thanks, question. And I forgot um, to mention that. So when there are several ways in which we can get a total effect or versus a control direct effect, non-parametrically, semi-parametrically, and fully parametrically. For this paper, we chose two non-parametric um, methods. And for example, for a total effect, what we did was use a weighted Allen-Johansen estimator. So we waited for all the confounders and we plugged them in an Allen-Johansen estimator that is calculating that cause-specific cumulative risk. And so we actually plotted the cumulative incidence over over time, and we just like choose the time points where we are mostly interested. So let's say at 20 years, and calculated contrast like a risk difference or a risk ratio and bootstrap confidence intervals. And under a control direct effect, what we did was a weighted Kaplan-Meier estimator. So the Kaplan-Meier treats death as a censoring event. So we added weights for death as well, in addition of weights for the confounder. So in addition to inverse probability treatment weights, we added inverse probability censoring weights. But these are the most straightforward ways because there's the software that is available to do them, and it's not that of a stretch to bootstrap point estimates. But we could have done this fully parametrically with pool logistic regression or other, or even with a COGS model, if you just trick the COGS model in different ways. Yeah.
Great. Yeah, thank you. There's a few more questions, but I'll leave you there for now to continue and we'll pick some more up at the end.
Okay, thank you. Okay, so I wanted to take this opportunity to describe some controversies that I found in the literature in respect to controlled direct effects. So, for example, Terry Turneau, who is the main author of the Survival R package, considers this hypothetical world in which we could have eliminated death as a discussion of survival after a zombie apocalypse. Um, and this is in the package documentation, so I thought that that was thrilling. We also have like there is this seminal paper by Jennifer Weave in epidemiology who first used inverse probability censoring weights for truncation due to death. And a commentary responding to that paper said that waiting for death is arguably a form of statistical cruelty. So, very strong opinions against the control direct effect. And also this very meaningful paper by Anderson and Keating from Statistics in Medicine has recommendations when we're analyzing competing events. And the recommendations are that one, we should do not condition on the future. Two, do not regard individuals at risk after they have died. And three, we should stick to this world. So these are all ways in which a lot of statisticians and epidemiologists have pushed back on using the control direct effect. So when I was in my PhD, I thought, well, if everyone hates this estimand, then why did it actually? Who made it up in the first place? You know. Um, so I just wanted to share a bit about the history of competing events analyses. And um, during the 18th century, there was a huge smallpox epidemic. And smallpox, there was no vaccinations, and smallpox inoculation was a controversial therapy because inoculation could actually kill you, but also smallpox could kill you. So there was this, there were no RCTs at that point to actually prove if inoculation would be an effective strategy to reduce smallpox death. Um, so what Bernoulli did is he wanted to estimate how inoculation affected life expectancy, and he considered smallpox deaths as a competing event for other causes of death. So he compared a hypothetical scenario. So he conceptualized this counterfactual world where everyone had been inoculated at birth. So in some way, eliminating smallpox death after inoculation. And he compared that counterfactual scenario to the observed life expectancy, and he concluded that inoculation would increase life expectancy. Now, we just have to remember that at that point in time, life expectancy was an indicator of wealth because it also referred to how much young people or like how much um, would be um, would be able to work on a specific place too. Um, so he compared these two contrasts to see if inoculation would be an effective treatment strategy as a public health intervention, let's say, because inoculation could also lead to deaths, but then is a trade-off of like some deaths due to inoculation versus people dying from smallpox, the disease itself. Now, another statistician, de Lambert, criticized Bernoulli's approach before the Academy of Science. And there are a lot of papers very interesting about this debate because he argued that Bernoulli was introducing a subjective bias into mathematical probability. And that this like hypothetical world that he was describing was shaped by moral and political views. And I found this very exciting because I it's like since the history of competing events centuries ago, there was already this like um, debate of the assumptions that we will never be able to satisfy and how these assumptions how are we willing to make these assumptions or not, and that these are very subjective. Anyway, so counterfactual scenarios such as preventing tuberculosis or cancer deaths became increasingly popular for studying life expectancy, and then that tradition has moved more in the area of demographics. So all these to say that at that point, there was no clear intervention to satisfy the consistency assumption that you could somehow eliminate death. Um, because there was still no proven vaccination for smallpox. But it's that thought experiment that now, if we look at it now in 2024, we don't see that that was such a crazy assumption. Um, and I'm very hopeful that based on how mortality has improved, and like the data that we see from cohort studies is like on population in the last century, and we know that mortality is decreasing at in midlife. So it's still like sometimes I think that it might not be that well to consider scenarios where we could have somehow prevented deaths, let's say. But if I know that both the total effect and the control direct effect are not fully satisfactory. So there are other estimates, so such as a composite outcome of dementia and death. There is the survivor's average causal effect, which has also led to a lot of discussions if it's actually meaningful or not, or natural direct effects. And a recent work by Matt Stensrud and colleagues are like showcasing new estimates such as the separable effects, which are effects of modified treatments motivated by the physical decomposition of the exposure, assumed to operate on dementia and death as separate pathways. So pretty much, if you can conceptualize that your exposure has different mechanisms that impact mortality versus the mechanism that impacts on dementia, and also it requires a lot of other assumptions, you can isolate a direct effect that is not equivalent to the control direct effect. So without that problem of interpretation that somehow we're eliminating death. And I think that this is actually it hasn't been implemented yet, but because initially I shared a slide where I kind of mentioned that many of the risk factors that we're interested in dementia risk could be considered ill-defined. That's actually a potential place where we can improve the way we are refining those exposures to the point that we are doing this thought experiment if we can actually decompose these exposures or not, and to understand the different pathways. And I think that that's like very intuitive, and we just need to keep pushing to refine our research questions in that way as well. So to summarize, when competing events are present, there is more than one way to consider them as part of our primary research question. So there's no way around. There's no adjusting. You just have to be very specific of what you're trying to estimate. So we have to let the question guide the most appropriate methods and estimators, and not the other way around. So we need to communicate as epidemiologists that all these questions are possible with their trade-offs, rather than continuing a narrative that one size fits all, such as use cause-specific hazards for etiologic research, or that only total effects should be calculated. And for these, we need to do more collaborative work between applied researchers, epidemiologists, and statisticians to narrow the gap between methods development and applied research. So just as next steps, things that I'm currently working on, and I would love to stay connected with people who are thinking in the same lines. One is, how do we map these estimates for continuous outcomes with death as truncation events? Because this seems that these are also like there's the statistics world that has its own estimates, and there's very little on the causal estimates that map with continuous outcomes with truncation events. And the next thing that I'm working on is exactly as I mentioned before, is what can we do if we only have data on those who survived up to certain age? So this problem that is called very commonly in literature survival bias, meaning that you had to survive until a certain point in time to be part of the study. But we know that, especially in early life exposures, those could have impact on your mortality. And so we are only looking to a very specific subset of people who have survived long enough. And right now, we're just even trying to map what are the estimates like there. Is everything a survival average causal effect, or can we, like, what does that even mean? So to finalize, I always like to end up with this quote by Carol Buck that says, "To search for all the refutable consequences of a hypothesis demands highly imaginative thinking. Imagination is needed to arrive at the hypothesis in the first place, let alone to suggest rigorous tests for it." So with that, I want to thank you all for attending. Muchas gracias. And I also want to thank all my amazing collaborators from my PhD and my postdoc that with who I've engaged in this very exciting conversation.